Hi, everybody. This is Tony. I know we're doing this episode on physician suicide around the holidays. For a lot of you, the holidays are a very joyous time of year. For some of you, this can be a very challenging time of year. If you're struggling, please reach out and get help. If you're contemplating suicide, please don't, and please reach out and get help. To reach the Suicide and Crisis Hotline, just dial 988 from any phone. That's 988. Suicide's a very important topic. We approach this episode with the utmost sensitivity and love. Now on with the show. This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. If you're new to the podcast, welcome. And if you're a regular, welcome back. As you know, I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And we have been coming to you since 2016. We're narrowing down on our 100th episode at this point, talking about topics important to pediatric hospital medicine on the content specifications. And once in a while, we veered off on topics that have a broader national relevance. And this one for physicians is one of those topics. It's a topic that's something we've been hearing about and reading about. And for physicians and healthcare workers, it is important. And I thought it'd be good to discuss. Now, to discuss a topic like this, you really need an expert because of A, the sensitivity of it, and B, you really want the right information. You don't want to just start throwing stuff around. And we are very fortunate to be joined with a true national expert on this topic, Dr. Sidney Zisuk. Dr. Zisuk is a University of California, San Diego Distinguished Professor of Psychiatry. He completed medical school at the Stitch Loyola School of Medicine and residency at Massachusetts General Hospital. He was the founding director of the UCSD Healer Education Assessment and Referral HEAR program, which is dedicated to preventing, reducing nurse and physician mental health stigma, burnout, and suicide. He currently directs the UCSD Physician Peer Support Program and serves as the Scientific Council of the American Federation for Suicide Prevention, Scientific Advisory Board of the Depression and Bipolar Support Alliance, and Board of Directors of the American College of Psychiatry. Over his career, he has published extensively on physician well-being, suicide prevention, treatment of depression, psychiatric education, and grief and bereavement. He's been a major contributor to the research leading to the elimination of the bereavement exclusion in the DSM-5 and to the development of the concept of and the best practices for treatment of complicated grief that led to the inclusion of prolonged grief disorder as a formal diagnosis in the DSM-5 TR and ICD-11, and to evidence-based and novel treatments for treatment-resistant depression. His many awards and honors includes most recently Educator of the Year Award, Psychiatric Times 2020, Lifetime Depression Research Award, American College of Psychiatry 2021, the Schwartz Center 2021 National Compassionate Caregiver of the Year Award 2022, Loyola Medical School Alumnus of the Year for Excellence in Research and Innovation in 2022, and the American Psychiatric Association Western Mark Psychiatric Educator Award. So, Dr. Zisuk, thank you so much for joining us. We really appreciate it.
Well, thank you, Tony, and thank you for that warm and extensive introduction.
Well, now, Sid, before we get started, this is a CME podcast, so we have to do our disclosures, our conflict of interest disclosures. I'll go first and kick it out to you. Now I have nothing to disclose.
Okay. Yeah, I do. So I receive research funding from a company called Compass Pathways Limited, which is a pharmaceutical company out of the UK that is primarily funding studies for psilocybin therapy in depression and other mental health disorders.
Okay. Well, thank you for disclosing that. Now, Sid, I guess we should start broadly. We'll start at the beginning. This topic came up because of the Washington Post article by Dr. Will West, who tragically committed suicide. It spurred on a good discussion in our pediatric hospital medicine listserv about this topic. And it feels like, at least to me subjectively, prior to doing the research for this episode, that this has been something that has been more and more pressing since the pandemic for healthcare providers. There was a famous article in the New York Times about a physician who committed suicide during the pandemic when she went home from taking care of patients. And overall, mental health for healthcare providers overall has gotten worse. Is this just, am I right about this? Is this just media coverage and it's just over exaggeration, or is there something here?
Clearly something there. It's a huge problem. The good news is we're finally talking about it. And I think media coverage has been very helpful in helping the dialogue move forward. Until we start talking about it and dealing with it, it's going to be hard to really prevent physician suicides and come up with the changes that need to occur in order to make this kind of a decreasing reality of the practice of medicine.
Now, Sid, based on what you said, normally I would ask something to the effect of, has this been worsening? Has this been a problem that's been getting worse since the pandemic? Because it does seem like healthcare provider mental health has gotten worse since the pandemic, especially in pediatrics after the triple-demic. But here, that's an epidemiology question. And here we get into the point of the data on this. The data itself is difficult to assess. Is that right?
Yes, the data is very difficult to assess, but I might say the problem's been there forever.
Yes.
And what we're now doing is beginning to address it and talking about it, but which is the best way we know to decrease stigma, by actually having physicians who have dealt with suicidal ideation and burnout and depression openly talk about it, or family members of a physician who's died by suicide talk about it. So I think the problem's not getting worse. It's that we're finally talking about it, which is a step in the right direction. In fact, there was actually recently a very nice review article that suggests that physician suicide actually has decreased a little bit in the last few years relative to the general population. Although it's still prevalent, it's still more common amongst female physicians than it is amongst other females. It's still more common amongst all physicians than in most other professional groups. So the good news is that we're finally beginning to see a decrease. The bad news is it's still a very prevalent problem, and we need to do a lot more work in that area.
Now, Sid, I'm going to ask you a rudimentary question, so forgive me for this, but we hear this all the time that it's important to decrease the stigma. As an expert psychiatrist, what happens after you've decreased the stigma on something? Is it just that more people will be comfortable if they have those issues asking for help? Is that why decreasing the stigma around physician mental health, physician suicide is so important, that people will come forward and feel more comfortable trying to get help if they need it?
Well, ultimately, that's the biggest issue. In part, by people talking about it more, folks who are struggling feel less alone. And it kind of helps normalize what they're going through so that they don't feel like they're a pariah, and they can access help. But ultimately, I think the most important aspect of decreasing stigma is opening up channels of help, both help from other individuals, from peers, from colleagues, from leaders in the field, but accessing mental health care, which is a huge problem, and maybe more so for physicians than for other people in the general population.
Now, I do want to get into the data, and here what struck me, I read, for those of you listening, Sid sent me a bunch of articles on this topic because he's an expert on this topic, and I read them and dissected them. And one of the things that stood out, you had an article in the Journal of Psychiatric Research in 2020, where you were the last author on. And just to evaluate the data, to extract information, to look at it, you had to do significant math just to have data to evaluate. Can you talk about that a little bit?
Well, there's no one single database. So a large part of the data came from the VDRS, the kind of national violent death database, in terms of looking at the number of people who, via coroner reports, died by suicide. But you can't. It's really important not only to know the number of physicians who died by suicide, but the number of physicians. And we had to go to a different database to get that number. Uh, and then each state has different regulations and different rules and different data. So we often had to go to each state to get their specific data in terms of overall mortality, overall deaths, the general population and general population suicide. So there, you had to combine a lot of databases, um, and the key database on identifying when somebody dies by suicide is not terrific. It's really based on the coroner's judgment, based on the information they have, and where there's not a suicide note, where it's not clear cut, where there may have been an accident that may or may not have been suicide, or an overdose that may or may not have been suicide. Uh, there's a lot of guesstimating, and we think it's likely that the number of suicides, particularly amongst physicians, is a gross underestimate of the reality.
Gross underestimate.
Yeah. So, we've, based on the data we have, we think there's 300 to 400 physician suicides a year, more than one a day. It's a large number in the United States alone, but it's not at all unlikely that it's a much greater number than that, actually.
And from your perspective, this has been a problem that's been ongoing. We're just hearing about it more now, which is helpful, but it hasn't been getting worse. It perhaps is even getting better.
Yeah, no, it's clearly ongoing. When I was a resident, we lost a resident colleague to suicide. When I started as a junior faculty member, another one of my fellow residents died. A medical student I knew died by suicide. My personal physician died by suicide. In all of those situations, no one talked about it. There were no newspaper articles. There was a conspiracy of silence. Now we are hearing about it. We are talking about it. We are honoring the lives of people who suffered and may have died by suicide. And so hearing about it more is a very positive thing, but it's been a problem. It's been out there for many, many years.
Now, you sent an article, and for those of you listening, I normally reference these articles in detail so you can look them up yourselves. I will have them if you take the CME question. I apologize. I lost the paper that had them I lost the file that had them. So it's a New England Journal of Medicine article on burnout and depression and physician suicide. It goes into how burnout and depression and suicide are all tied together and how difficult burnout is to actually measure. And we don't, as a society, have one accepted definition of burnout. And it talks about why. So why, since they're so tied, first of all, you agree, I'm assuming, that they're very closely tied together.
They are. And burnout often is diagnosed instead of depression, because there's no stigma attached to it. And can often mask an underlying depression, which can be a real problem. But they are related. In fact, one of the risk factors for physician suicide, more so than other people's suicide, is job stress. And so that would suggest that burnout, which is a reflection of job stress, is important to identify and to manage and to attenuate and prevent as best we can. But many people, the majority of physicians who have a clinical depression will also meet any criteria for burnout, because when you're depressed, you're unhappy, you're not satisfied, you're not doing as well wherever you are, you're more stressed, so you're going to be burnt out. They burnout and depression are often intermixed and intertied, but pure burnout in the absence of depression is very different than when burnout is accompanied by depression.
I guess my question is for the MBI, one of the tools we have to define burnout, but it's not great. And we don't agree on which form of that we're going to use. How has this been so challenging to establish a unified definition for burnout?
Well, so burnout's not a medical diagnosis,
Right.
which I think is part of it. And the Maslach Burnout Inventory, the MBI, is a very nice instrument, and it identifies burnout as having three components: one, emotional and physical exhaustion; another, cynicism and depersonalization; a third component being a feeling of ineffectiveness. But it's a long questionnaire with many questions. It's a copywritten questionnaire, so it's not readily available for anyone to use. So it's there, but how to score it? Should we score it as categorical? A person has a certain score and they're burnt out or not burnt out, or is it a dimension that people have relative degrees of burnout at different times and in different places? And there's no general consensus on that. There was a very interesting study, a meta-analysis of studies on burnout, and it discovered that out of I don't remember the exact numbers, but out of something like 300 different papers on burnout, there were about 250 different definitions
Yeah.
and instruments used. And a lot of people will use a single instrument, are you feeling burnt out as the measure? And others use two or three questions. So there's great variability. And that's why the rates are so variable, depending on whose survey you're looking at, because they're measuring it in different ways.
That's the part that struck me is the rates. The rates really vary depending upon who was measuring it and how.
Yeah,
Now, the HERE program you established and helped spearhead out of UCSD, in the study you sent me, you all included nurses into the HERE program. Is that right?
that's correct.
And then what you found, there many more nurses were affected with depression or burnout than physicians were. And that honestly surprised, probably didn't surprise you clearly, but it surprised me than the disparity in that. Can you talk about that a little bit? How, nurses are at the bedside way more than physicians are. They're there all day. Their shifts are 12 hours typically. So I can see it now that I'm looking at it, but I did not notice that.
Well, the things you mentioned are all some of the reasons. I think nurses carry a great burden, and nurses often are very compassionate people, and compassion can only take you so far before it starts to become a burden. And the other thing is, nurses are predominantly women. Women have higher rates of burnout and depression than men do. But even when you correct for gender, nurses still had higher rates of both burnout and depression. I think we underestimate the job stress. They have less support. We have started at UCSD, for example, a physician peer support program. That's what I run now. We don't have a nurse peer support program yet, and that's typical of many, many places. We added nurses to the HERE program in 2016. The HERE program started as a physician suicide prevention program after a series of physician suicides in our facility. In 2016, we discovered there were 3 fairly recent nurse suicides, and the nurses got them and said, "Wait, what about us? Are we invisible? Don't we count?" And they were ignored. And people didn't take it as seriously, and the job stress went less supported, under-recognized, et cetera. So we were delighted to finally bring them into the fold and discovered that, in fact, nurses even had more burnout, more depression than physicians did. And so that's been a target group for us to provide more support to.
Sid, I love when you talk. I have so many questions based on everything you tell me. So I'll start with the peer support program. We have one of those in Pittsburgh as well, the physician peer support program. That was one thing I didn't read. Have they been shown to help with burnout or suicide or depression? Has there any data around them? Or even anecdotally, have you found that them be helpful?
Anecdotally, I think they're very helpful. There's very little data. I actually tried to scan the literature on data showing their effectiveness. I actually think that that physician peer support programs, or healthcare peer support programs in general, are not only helpful for the people receiving support, but helpful for the people giving the support. And what feels better than supporting and listening to and helping a colleague who's suffering or distressed? But the other thing is it's part of a shift in culture. We're trying to really shift the culture of medicine into one where people feel connected, people care for each other, people are more open about the emotional aspects of the job and the emotional stresses. In having peer support is part of that shift in culture, which is an essential one. And I think if effective, can decrease the need maybe for formal mental health care, or at least expedite referral to formal mental health when it is indicated. But the data on that is still lacking. And I think in part because peer support programs are brand new. They're just starting. I think we will be getting data on their effectiveness over the next several years.
There's an old saying where getting physicians together is like herding cats, where it's very hard. You want to change the culture to where it's more, as you said, unified. Everyone cares for each other and looks out for each other. How challenging has that been? I mean, physicians are really traditionally stoic kind of individuals, keep to themselves, do the work, but to change it to that degree, I can imagine it's hard.
It is. That's one of the problems is, the personality of physicians, the perfectionism,
Yeah.
the not accepting being less than superhuman in any medical error that occurs is your fault, you're to blame. You're ashamed. No one else could do it. You have to deal with it in silence. We've got a culture of stoicism and toughing it out and not asking for help. And that's one of the things we need to overcome. And changing culture is really hard, as you alluded to. And so we need to take all the baby steps possible. And one of those baby steps is developing peer support, encouraging people to talk about stresses and emotional issues that they're going through, or talk about depression and seeking help and how it's helped. So, there are many steps we need to take to shift that culture. But the culture of physician that you and I inherited when we got our degrees,
Yeah,
is one that's there's interestingly, there's also a culture of wellness. Take care of yourself.
yes,
Balance life and work, eat
sure.
well, sleep well. And we are beginning to preach the culture of wellness to our trainees and junior faculty. And that's great. And to a large extent, they're buying into it. And they want that. But we old guys need to come to grips with it and accept that that culture of wellness is equally valuable to our own culture of perfectionism,
Yeah.
and we need to shift.
So along those lines, one of the most interesting parts of that HERE program article you sent me was the discussion that burnout was related to workload, hours worked, was a clear, so those long hours worked were a clear cause of burnout. But after the hours were decreased, it seems as though the burnout scores didn't improve. Am I right about that?
Mostly right.
Okay.
They're starting to improve again. There's some data. There's a Medscape survey, the 2024 Medscape survey, has shown that actually rates since about 2022 are starting to get better. And I think the problem is that the work hour changes, which occurred, like 2003 or so, it took a while for them to take hold, and there were so many other variables that occurred. So if you decrease the number of work hours, that's great. But if you don't decrease the workload, that may not be so great. Or if you siphon off some of the less critical and less severe patients to physician extenders, but
Right.
keep the same number of the really difficult ones for your residents,
Yeah.
who have to now see them in fewer hours, don't
Yeah.
have the advantages of continuity of care, or if those hours come out of supervision and educational time and didactics, you're not helping. So there's so many other factors that I've entered in. There have been some studies showing that the decrease in work hours is associated to some extent with lessening of burnout, but they're not terribly consistent. And So I think the answer is there. There was really a very interesting article recently that came out on depression, that since the duty hour changes and since residents are sleeping more, since residents are more likely to access mental health care, that there has been a decrease in depression occurring during residency, particularly this study was during internship. So that's a positive sign. And I would guess probably also a decrease in burnout during that same period, although that wasn't measured in the study. That study was measuring depression. So I think the workload is related to burnout, and decreasing workload is a step in the positive direction, but it's one step. And I think to really decrease burnout or to decrease depression or to decrease suicide, multifactorial. There are many, many things that have to go into it, not just one simple change.
That is so. And the one thing you mentioned that I want to come back to, that when you talked about female physician suicide death rates were higher than their non-physician female counterparts.
Correct.
In the Journal of Psychiatric Research article.
Right. And we've just done another study updating it since and found the same thing.
The same thing.
Female physicians still die by suicide at a greater rate than females in the general population.
And I happen to work in a field that is overwhelmingly, predominantly female. I think we're at like 85%, somewhere 75, 85% female in pediatric hospital medicine. What is there besides work hours and stress from job? Has there been anything else you found associated with this, like work-life balance? Traditionally, there's been a lot of data that shows female physicians, if they're married with children, have more duties at the house, responsibilities at the home. Have you found that at all played into it?
Sure. There's really no good studies of that, but there are so many factors. I mean, women the salaries tend to be a little bit lower. There are fewer women's in leadership roles. There are fewer openings for women in leadership roles. Women are still dealing with sexual discrimination, and in some cases, sexual harassment in the workplace, that much more so than men. But I think the biggest single issue really relate to women being much more likely to have two full-time jobs, one being as a physician and the second being as a mother and wife. And, my daughter's a physician married to a physician. Guess who does the carpools? Guess who plans the camps and it's just, I think, much more demand on women than you and I have. As their male counterparts.
So now what really came up in the listserv was about trainees, because the Washington Post article was a trainee. And a lot of us in the hospital medicine community are teachers, right? So we are in charge of the wards. Our residents, medical students rotate with us. We see them a lot. We'll have fellows as well. And there was a lot of discussion about what we can do as teachers. Now, everything I've read that you've published are large programs, institution-wide. What advice would you give for those who have a team? Is there anything that can be helpful here?
Well, I think there's probably lots of things that we can do. Well, you mentioned team, and I know for me and for many people, being part of a team is really good. So, team meetings, huddles before and after the workday, I think can be very helpful. I think that for any of us who have dealt with burnout or depression, to openly talk about it, to be a role model, to let people know, any of us who have accessed help and benefited from it, whether it's peer support, talking to a colleague, getting therapy, getting on meds, to be open about that and to be a role model for others, letting them know it's okay to deal with the emotional aspects of being a physician. It's okay to admit that we're not infallible. It's okay to admit that if we have a mental illness or mental condition, that we access help. And in fact, it's not only okay. That's the courageous thing to do. That's the professional thing to do. That's the way to provide the best care for your patients. Uh, so I think role modeling is important. Creating a team approach is important. I think listening and paying attention when the kind of the suicide. It's very difficult to predict suicide, but we do know some risk factors, and we do know certain kind of telltale signs that may reflect an imminent suicide. The way someone behaves as they start to withdraw, if they start to not attend, if there's reason to think that they may be starting to drink more, the giving away possessions. Listen to what people say. If people talk about being a burden, about what's the use of going on, about feeling as though they wish they could just give up or do away with themselves. So listen to what people say, observe what people do. Certain feeling states may reflect an imminent suicide crisis, like feelings of hopelessness, helplessness, despair, severe anxiety. So I think paying attention to those warning signs. But I think ultimately to create an environment where we're caring for each other, where we're sharing, where we're connected, and encouraging the kind of behavior as much as we can, it can be extremely helpful. And that's part of shifting the culture.
And then if you're in that kind of environment, at least for me as an attending with a team, if I notice someone where I'm concerned, one of the first things I'll do is talk with them and see and just try to give open-ended questions, see if they'll talk. And then otherwise, at least if they're residents, alert the program directors and let them know, hey, I'm a little bit concerned about this or that resident. Could you guys check in on them? If they're medical students, I'll let the course directors and the medical school know, hey, I'm a little bit concerned. Could you guys check in on them? But yeah,
All of the
I was,
above.
what's that?
I agree with all of the above.
Yeah, I was really hoping for a silver bullet, easy, direct way to figure it out and intervene, which is kind of what was discussed a little bit in the listserv on what we can do and how we can be sympathetic and compassionate. But from what it sounds like, it comes down to being a good listener, creating a non-judgmental environment to learn in, where everyone feels comfortable speaking, talking, asking questions, and then listening to what they say and looking for cues.
Yeah. And the other thing is just, we didn't talk about all of those. I think are important, but expressions of gratitude, people who feel valued, do better. And we're starting to do that a lot more. Thank you
Yeah.
for all you do, and really showing appreciation rather than expecting someone's always going to do a great job and be compassionate and provide good care, to acknowledging it when people are doing a really good job. And expressions of gratitude can go a long way in terms of enhancing well-being in the workplace.
So I didn't think of that. So we do things like kudos for the residency, at least, where if a resident goes above and beyond, we'll send to the chief residents kudos. And at one of the residency meetings, they'll just run the names of the residents who got kudos for this or that. They went above and beyond for this patient or did something really spectacular, made a very challenging diagnosis. You're saying all of that together makes someone feel more appreciated and then can lead to increased well-being and perhaps decrease the risk of suicide?
Well, perhaps.
Perhaps.
I think, again, workplace stress for a physician is
Yeah.
one of the triggers for suicide. In the kind of coroner's reports on physicians who have died by suicide, kind of looking at what was going on immediately before, physicians more than others had been involved in some kind of workplace stress or displeasure, exhaustion, and so I think one of the things that we can do, hopefully, that will decrease the incidence of suicide would be those kinds of expressions. Any ways we can connect with people.
It always boils down to what seems like the simpler things, and it I guess it shouldn't be surprising, but humans thrive to want to be connected, and when we're disconnected, we don't do as well. But when we're connected and feel as a part of a group and feel valued and cared for, we tend to do better.
Correct. Correct. And it doesn't necessarily take much to help someone feel connected. There's interesting data on not physician suicide per se, but in suicide in the general population that after an individual goes to the emergency room because the suicidal ideation or some suicide related event or thoughts, that just simply a phone call by the emergency room staff or even a postcard by the emergency staff after the visit can decrease rehospitalizations or other emergency room visits or, future suicidal ideation. So, simple ways of connecting people, helping them know they're not alone, helping them understand we care can go a very long way. And that's not only with our residents and our medical students, but with our colleagues and friends as well.
Yeah, it sounds like big institutional wide programs like your HERE program and the peer support program are helpful, but even smaller divisional grassroots events like coffee time, lunch together, having people over for dinner once in a while, those types of and for the resident teams and the medical student teams getting together, having coffee if you on rounds once a week. It seems like all of that's a part of this.
I couldn't agree more. I think it starts there at the very local level.
Yeah.
Uh, the departments, the clinical services, the units, and then builds from there.
So this has been really eye-opening, and I, this it's a sad topic, and we're doing around the holidays, but around the holidays, it is more stressful and more difficult in a hospital setting. So in essence, I chose to do it this time to help those who are stressed around the holidays working and in pediatrics, at least, our admissions go up because everyone gets together and passes the viruses around and flu comes in and it becomes a bigger issue. Is there anything we didn't talk about that you think is relevant for us to discuss here?
Oh, probably about 1,000 things, but I think we've probably covered enough. The thing, I'm just so delighted that you're doing this and that you're including things like well-being and suicide prevention in the curriculum. And in other places, more and more are doing that as well. And so let's keep up the momentum.
The one thing I did want to bring up that I don't think we brought up, the overall mental health of the country, anecdotally, again, I don't have data for this, there's more anxiety, more angst, and is worse from the pandemic, political issues, societal issues, all of it together has made the mental health of the country worse. Do you have any data, or do you have a feeling from your expertise that this is also affecting physicians more?
Well, I think so one of the issues that you raised is COVID.
Yeah.
So I think COVID affected everybody. Rates of depression and suicidality and burnout went up in COVID for everybody. But I think that COVID probably affected physicians and other healthcare workers even more than the general population. Especially those frontline workers who were in the hospital every day, and especially nurses who were
Yes.
in the hospital every day, and really the ones that had the most contact with patients, the most fear of contamination or bringing it home to their families. So I think COVID uniquely affected physicians and other healthcare workers to a greater extent than most of the general population. Other first line workers, obviously, as well. But the things like, the election, the wars we're going through, the economy, it probably affects everybody equally.
Now, for our listeners, I found the articles, I found the paperwork I was talking about. So the first one is Supporting Healthcare Workers' Well-Being and Suicide Prevention, the HERE program from May 2009 to April 2023. And the second article is Burnout, Depression, and Diminished Well-Being Among Physicians, New England Journal of Medicine, October 24th, 2024. So very recent. And one of the points that I should have pointed out, and I did not, is that one of the reasons we talk about this is diminished well-being among physicians is associated with poorer outcomes for the physicians themselves, which makes sense, but also the patients we treat. So it's important for us to keep this in line to help both us, which is important, and our patients that we're managing at the time.
we owe it to our patients to take care of ourselves, and we owe it to our families, and we owe it to ourselves. But if you're going to practice medicine at your highest level of competency, you've got to do it at your own highest level of both physical and mental well-being.
Sid, there was one part of this New England Journal of Medicine article I circled. This is one of the best lines and made me ask a question. I'm going to ask it to you. Physicians often have to shoulder heavy responsibility, but increasingly are limited by low autonomy and low decisional authority, a combo that is particularly stressful. To me, that means the physicians 2 generations ago who had all the autonomy should have had lower rates of burnout and suicide. And what you're saying is that's probably not true.
Well, they might have had lower rates of burnout. We don't know because we weren't measuring burnout then. I think in my own personal case, an N of 1, that's very true. When I felt I had more autonomy and when I wasn't stuck with all this documentation and Epic and EVUs or RVUs, I was much more satisfied in the field. So in my own personal life, having more autonomy, more independence, doing the things I valued, having more freedom, rather than having someone else telling me what I need to do every day and documenting it for the insurance companies rather than for the welfare of my patients. That's created a difference in the level of burnout I've experienced in my own life. And I think that's generalizable. I think that's probably true for most of us. We don't have great data on that, but how can it not be?
I would agree. And the one other part we didn't bring up, this is another article, Physician Death by Suicide in the U.S., 2012-2016 by Dr. Gordon Yee. And Sid, you are the last author, and this is the Journal of Psychiatric Research in 2021. The most common method of suicide for physicians, the first was firearm, and the second was pharmacologic poisoning, which I thought was important for us to know and talk about. This was really good to read, really good to learn about. Clearly not a happy topic, but an important topic, especially for those of us who listen to the podcast, who have trainees, have medical students, just to bring up, to keep in mind as we go through and train them and teach them. We picked up tips on how to make what we need to make a more inclusive, welcoming environment so people feel comfortable coming and talking about these things and making it seem less stigmatized, and ideally all of us more connected, which when you say it all in one sentence is a big to do.
Yeah.
Sid, yeah, anything we didn't talk about that we should talk about?
I think we've pretty much covered it. The kind of physician stressors, we didn't talk about legal issues as a fairly unique stressor. But I don't think we really need to get into the nitty-gritty of those kinds of things. So I think we've pretty much covered the topic. And it's the good news is that we are talking about it. The good news is the latest Medscape survey shows less burnout now, way less burnout now than at the height of COVID. The latest data on physician suicide suggests it's going down rather than up, which is a change.
Yeah.
The latest data on general population suicides is it's finally not increasing anymore in the U.S. It's at least stable, if not going down. So I think there's good news, and I think that one of the reasons physician burnout and suicide is starting to go down is that we're talking about it more, we're destigmatizing it more, more people are accessing healthcare. The one thing we didn't talk about was how difficult it is to access mental health care. That's a huge problem. We have resources, most of us have insurance, but go find a psychiatrist that has an opening. And so that's a huge problem that we probably can't solve today.
No, and you could take that problem to just about any subspecialty in pediatrics or adult medicine today, where there's just not enough of us and there's too many patients that need appointments. Yeah, that's a very difficult
I'd like to see us in mental health care provide more of it at the institutional level, but so that it's accessible and feasible, and physicians can access it in a reasonable way. But in some cases, it's starting to happen a little bit, but not enough yet.
Well, Sid, I can't thank you enough for being on the show. I thought this was a great episode. I really appreciate it. Thank you.
Thank you.
And happy holidays, everybody. We will see you next time.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.